Welcome to Cardiovascular Innovations Digital 2020. My name is Ijioma from Mayo Clinic. This is an 8-minute presentation on the Stent Will Not Expand algorithm. This presentation is part of the CHIP Part 3 Access and Stenting series. I have no disclosures. A patient presented to our lab with angina. As shown in Figure A, corneal angiography revealed a patent LAD stent with minimum in-stent restenosis. There was a stent in the second diagonal artery with about 50% in-stent restenosis, and just distal to that diagonal stent there was a diffuse lesion. As shown in Figure B, balloon angioplasty was performed of the lesion in the second diagonal artery with a 2.5 mm non-compliant balloon inflated at 20 atmospheres of pressure, and as shown, the balloon would not fully expand. As shown in Figure C, further balloon angioplasty was performed with a 2.5 mm cutting balloon, and once again, the balloon would not fully expand. So, what would you do next? Would you place a stent? Would you perform further modification of the lesion? Or would you give up? So that brings us to our talk on the unexpandable stent. What are potential etiologies for this problem? The first, unrecognized calcium. The second, fibrocalcific lesions. Remember the lesion in our case presentation? It did not look heavily calcified, but the balloon would not fully expand. The third, suboptimal plaque modification of a heavily calcified lesion. And the fourth potential cause is stent deployment in a non-dilatable lesion. It's important to recognize that the risk for an unexpandable stent is a dog-boning balloon, just like we showed in our case presentation. So here's a management algorithm for an unexpandable or underexpanded stent. Non-compliant balloon, atherectomy, this could be rotational or laser atherectomy, and intracoronary lithotripsy. Once again, this algorithm is for an already deployed stent that is not fully expanded. Before we do a deep dive into that management algorithm, I would like you to think about the unexpandable stent as potentially presenting in two different clinical scenarios. The first is a newly deployed, freshly implanted stent that does not fully expand, and the second is a previously deployed old stent that is not fully expanded. And usually these present either as in-stent restenosis or stent thrombosis. So returning to a management algorithm for the unexpandable or underexpanded stent. The first strategy is non-compliant balloon. You can take a non-compliant balloon, either the same size in diameter as the stent or just slightly bigger in diameter, and you can post-dilate that stent at high pressure, about 20 to 25 atmospheres of pressure. Watch out for potential complications of corneal perforation, corneal dissection, or balloon rupture. You may ask, what about cutting balloons? Can these be used? Now, for cutting balloons or atherectomy balloons, while these cause direct fracture of luminal calcium, ideally these cutting balloons should be used prior to stent implantation, because that provides maximum contact between the cutting balloon and the plaque surface. Now, the other management strategy is atherectomy. And there are two ways of doing this for the unexpandable or underexpanded stent. The first is rotation atherectomy. The second is laser atherectomy. For rotation atherectomy, this uses a diamond-tipped burr, which comes in different diameter sizes, and under high-speed rotation debulks that calcified lesion, fracturing the plaque calcium. You do want to watch out for burr entrapment, which can occur from the stent struts. And to minimize that potential risk of burr entrapment, we recommend starting with a small size burr and then increasing the burr size as appropriate. And when you start the rotation atherectomy, it's important to use slow, gradual pecking movements of that burr, and that helps avoid burr entrapment. It's also important while performing rotation atherectomy to watch out for excessive stent damage as a rotational atherectomy can cause partial removal of the stent strut. Also watch out for distal embolization and no reflow phenomenon due to microvascular embolization of plaque debris. Remember, rotational atherectomy is relatively contraindicated in thrombus-containing lesions due to that potential risk of distal embolization or no reflow phenomenon. The other option for atherectomy is laser atherectomy. And unlike rotational atherectomy, the laser catheter does not need to cross the lesion, neither does it need to come in direct contact with the lesion to cause plaque modification. Laser atherectomy can be performed either without contrast or with simultaneous contrast injection. When performing simultaneous contrast injection, the thermomechanical effect of the laser atherectomy is magnified and is able to modify that calcified plaque beneath or underneath that stent strut, even without coming in direct contact with the plaque. If performing simultaneous contrast injection with the laser atherectomy, we recommend using a small 0.9 mm laser catheter to minimize the risk for coronary dissection. The third management strategy is intracoronary lithotripsy. This is a novel technique. It uses a balloon to produce high-power acoustic shock waves which disrupt the calcified lesion. It can act on both superficial and deep calcium. It acts on the calcium beneath the stent struts. And another advantage of the intracoronary lithotripsy technique is that it reduces that risk of distal embolization by entrapping the fractured calcium within the vessel wall. It is important to pay attention to the time that is involved in the intracoronary lithotripsy, because during that time of balloon inflation to deliver the acoustic shock waves, the vessel may be occlusive to blood flow, and so there could be some ischemic changes. In conclusion, prevention is better than cure. Optimize calcified lesions prior to stent deployment. Intracoronary imaging, whether IVUS or OCT is your friend, use it. Know your tools for modifying calcified lesions, and these include non-compliant balloons, atherectomy, and we've talked about their atherectomy, laser or rotational atherectomy for the unexpandable stent, and intracoronary lithotripsy. Thank you for listening to this presentation on the algorithm for the unexpandable stent, and I acknowledge my mentors. Thank you.